Please mute their audio. That would be great. Welcome to OASIS-C1 Coding and the New Recalibrations, What This Can Mean for Your Agency, presented by the Visiting Nurse Associations of America. This continuing nursing education activity was approved for 1.25 contact hours by the Maryland Nurses Association and accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. Following the webinar, each registered participant will be emailed a link directing them to an online quiz and evaluation. In order to receive your certificate of completion, you must attend this webinar in its entirety and complete the online quiz and evaluation you receive via email. You must earn at least a 70% on the quiz to receive your CEUs. Please ensure all contact information you enter is correct, as this is where we will email all certificates. We ask that all online quizzes and evaluations are completed by Thursday, June 11th, 2015 to receive credit. Our faculty has disclosed no conflict of interest. Now, it is with great pleasure that I turn it over to our guest faculty, Susan Carmichael, Executive Vice President and COO with Select Data. Susan?
Hey, thank you so much, Heather, and thank you everyone for attending. Looking forward to talking with you today about OASIS-C1 coding and the recalibrations. Many of you may know and may be feeling some of the changes that occurred with the new recalibrations. I know in the April 27th issue of Home Healthline, there was the survey respondents and to a survey asking if there had been impact from these changes, and over 54% of the 152 respondents said they were losing between $101 and $300 an episode. So we're going to be talking today about why some of the changes occurred and what we can do about them. So looking forward to chatting with you. If there are any questions, as Heather said, please don't hesitate to submit those in the chat session. And then at the end, of course, perhaps we can have some dialogue if there's any questions there. So thank you so much, and let's begin. First of all, this is not legal advice, but I'm sharing the information with you as stated in several of the reference sources. And today we're going to be talking about the OASIS changes, the item intent, the response-specific instructions. We're going to be talking about general diagnosis and M questions that no longer do garner mixed points. And we're going to be talking about the reasons why there were the changes, as well as looking at the focus of your agency, some things that you may wish to consider now given the new recalibrations. So the big question, I guess, is why change? Why bother? Well, essentially it was planned to coincide with the big event of ICD-10, which of course you know now is occurring this year instead. So technically ICD-10 begins on October the 1st, 2015, just less than 5 months from now. No further delay. There have been several bills in the House and Senate where there was the possibility where there could have been proposals to delay it. There's been no delay. So it's really felt by the industry as a whole that ICD-10 is going to occur. So for anybody that you know, it certainly won't be you, anyone that you know that may be out there still wishing and hoping, ICD-10 is going to be here. The OASIS-C1 changes were important enough, though, to go ahead and make the changes even with the delay last year of ICD-10. And the M items were updated for simplification and clarity. And essentially what you find is we had so many of the changes last year that this year with ICD-10, we'll see very few changes on the OASIS-C1 ICD-10 document. Essentially, we'll just be dealing with ICD-10, and that's probably enough. So if you're looking for an OASIS, this may not have been the one that you've been wanting all along, but this is the one that we have in the industry. Now, some of the reasons... I'm sorry? Some of the reasons that you find there were the changes were to retire the outdated Q&As, revise the Q&As to clarify guidance, update the C1. There were typos. They wanted to standardize language. They wanted to have capitalization across the board. And again, they wanted to be certain that we would be reassured the Q&As will still continue as they were before.
If you're on the call, please go ahead and mute your line. We can hear the audio that's going on in your background.
A number of the changes that did occur with the modified version of OASIS-C1, as you know, we had OASIS-C1 and then they had to modify it to the ICD-9 version, essentially going back to having M1010, 1016, 1020, 1022, because we weren't going to be using ICD-10. That'll revert this coming October. One note, though, for those of you that are thinking you have nothing to worry about till October 1st, do remember in home health that that episode beginning on August the 3rd, we will be seeing dual coding. You'll have ICD-9 codes for your rep, and again, you'll have ICD-10 codes for your final claim if indeed it falls over that October 1st deadline. Now, one of the functional changes of many, you'll note that in M1830, the guidance stated to choose answer 5 if the patient was unable to bathe in the tub or shower and needed intermittent or continued assistance. The big focus here was how is assistance defined, and I've added that convention for you. When an OASIS item refers to assistance, it means assistance from another person unless specified. So assistance isn't limited to physical contact and does include verbal cues and supervision. Another thing to keep in mind here is bathing excludes washing the face, hands, and shampooing the hair. So one of the things we find when we do audits is that essentially, and we're going to talk about this again, conventions need to be reviewed with clinicians because there does seem to be some confusion at times amongst clinicians as to how to interpret the guidance.
No, I thought it was Deborah. I paid for it, I registered, and then forgot to send it out.
Hi, if you just joined the line, please mute your line. We can hear your audio. Thank you.
Note the functional changes too. The word specifically was added. OASIS-C guidance stated self-care does refer specifically to grooming, dressing, bathing, and toileting. And household tasks refer specifically to meal preparation, laundry, shopping, and phone use. So keep in mind throughout this presentation, we're going to note the emphasis is on the functional items and on skin throughout the changes in OASIS-C and its recalibration. Now, the clarification in the skin questions, in 1334, the guidance states newly epithelialized should not be selected for a healed stasis ulcer, as a completely healed stasis ulcer is not reported as a stasis ulcer on OASIS. So we're going to get some of these kind of household things out of the way that we saw throughout, and then talk about some of the diagnoses here. But let's take a look at one of the important ones, M1033, risk for hospitalization. Note that they removed the statement to use professional judgment. And they also deleted the definition of frailty as it's no longer a response option. The removal of the statement to use professional judgment has caused some discussion in the industry. The question was why. But what you're going to find is more and more CMS is moving towards validated assessment tools and moving away from subjective evaluation. Now, also based on a public comment, response 7 was changed from currently taking 6 or more meds to currently taking 5 or more meds. So that was a change, and please note it. Also, the number of answer options was expanded, so it's much larger now. Timeliness and prevention are seen to be a focus in OASIS-C1, and this means that this is where the auditors are going to be reviewing. So they're looking at prevention. Are we indeed administering the influenza and the pneumococcal vaccines? Are we using formal pain assessments, intervening, monitoring, mitigating pain? Are we doing risk assessments frequently regarding pressure ulcers? Are we instituting preventive measures? And are we treating based on specific principles for wound healing? For physician notification, are there patient-specific parameters for reporting changes in vital signs? And here's where it's been noted that clinicians tend not to be as specific in their documentation, and it's hurting us. And this is one of the reasons why we're losing some case mix diagnosis, because we're not as specific in our documentation as to what we have done, when we've notified physicians. The specifics there, the pertinent clinical findings are necessary. Again, for heart failure, screening for symptoms, what actions were taken specifically? And for depression, what symptom screening was completed? What interventions were implemented? Med management, the drug regimen review, was there notification of a physician? And was it significant? And was it within the 1 calendar day? And was there specific drug education to the patient and or the caregiver? Also, another area of focus is diabetic foot care. Now, even though we lost case mix points for diabetes as a primary, although we're going to be discussing that also, diabetic foot care and diabetes is still, we're going to be seeing it, and we still need, of course, to address it. So monitoring for lesions on the lower extremities and education on proper foot care. Again, we mentioned the vaccines. This was an area of focus, and again, prevention. CMS is looking to see that A, we are indeed identifying the patient who was receiving services from the home health agency during the time period of the influenza vaccine data, and was it collected. They also clarified the time period. There was confusion regarding reporting the influenza vaccine status. That was clarified. So you can see throughout the OASIS-C1 a lot of cleaning up as far as typos or statements, clarity, questions that had arisen, getting them answered, making the tool easier to use. Now, CMS is demanding that we have a specific reason why the influenza vaccine was not received. And they simplified it to report the reason, basically wanting specific answers. Note that response 8, none of the above, was changed to no, patient did not receive the vaccine due to reasons other than those listed in responses 4 and 7. Please note that 4 to 7 are yes responses, 5 through 8 are no responses, and this can impact your process rating with a no. So note the specificity thought throughout the document, including this particular area also. Now, with the pneumococcal vaccine, same thing. CMS is cleaning this up. They want more specifics. They want to identify whether the patient has ever received the vaccine. Some housekeeping areas, they changed the abbreviation and spelled out pneumococcal vaccine. Again, 1056, they want to know why the patient has never received the pneumococcal vaccination. So very specific. If we gave it, fine. If we didn't give it, why not? And they want the specifics. For unhealed pressure ulcers, the language was revived to be in accordance with the WOCN, their guidance document. Pressure ulcers that the care provider suspects may be present based on clinical assessment, but cannot be staged because no bone, muscle, tendon, or joint capsule stage 4 structures are visible, and some degree of necrotic tissue or scabbing is present that the clinician believes may be obscuring the visualization of stage 4 structures. So again, taking a look at specifics, attempting to make certain that we're all on the same page when it comes to definitions. And you'll notice referring to the specific guidance that they're going to use as their source material. In M1307 and 1308, the term non-epithelialized was eliminated, and the NA response to once again improve clarity. They also added the exclusion of healed stage 2 ulcers and even capitalized words like unstageable throughout the document. So this looked like initially a cleanup, but then when you go in, you can see specific areas that they were honing in on. Wounds were honed in on. Functional areas were honed in on. One of the interesting things was that M1309 collects information at discharge, which was previously collected in 1308, regarding the worsening of a pressure ulcer. It's looking to compare the current stage to the stage of the most recent start of care, or the ROC. Now, when they did this, they harmonized the language with the nursing home MDS and the care instruments. So let's take a look at that. You're beginning to see that this cleanup looks, as far as definitions, typos, things like that, has a longer message to us, a greater message. It looks as if they're attempting to harmonize this tool with other tools that are out there in the continuum of care. And there's been a lot of discussion that eventually the belief is there would be one standardized tool to use throughout the continuum of care, or throughout the entire episode. And remember, CMS looks at episodes as when a person was admitted to the hospital to when they've been discharged from post-acute care, that whole episode. So the belief is that they're looking to have a more standardization amongst the tools used at the various levels of care. Note that in 1309, the focus on whether the ulcer is new or has worsened when compared to the start of care or the ROC. 1330, 32, and 34, which stasis ulcers are observable, which ulcer is most problematic, really honing in on to the specifics. Now, in 1500 and 1510, heart failure, the wording again was clarified. There had been questions in the past, clarified to include the time of the assessment. Now, here's where you may want to really take a look at some of the conventions, and I believe you also received a handout. I included the general OASIS item conventions. Now, most of the people on this presentation probably know these conventions inside and out. But again, when doing audits, some of the things that I've noticed are there are certain conventions that seem to cause clinicians some pause. So if you take a look at them, convention number 1, understanding the time period under consideration for each item. This is not necessarily understood by all clinicians, and it's worth reviewing with them. They should report what is true on the day of the assessment unless a different time period has been indicated in the guided language. And that means that assessment is defined as the 24 hours immediately preceding the home visit. So when they're talking with the patient, they should be noting what's occurred in the last 24 hours. Number 3 is another one that you tend to find there's some confusion with this. If the patient's ability or status varies on the day of the assessment, you report their usual status. And what is true, greater than 50% of the assessment time frame, unless the item specifies differently. And this is something that you don't always see the clinician answering properly. Another one that you really should focus on is number 7 when we're talking about assistance and what does that mean. Frequently, clinicians do not consider verbal cues as assistance or supervision, and they really should reconsider that. Number 9, understanding what tasks are included and excluded in each item is very important, as well as number 10, we see confusion there. And this is probably one of the biggest ones when it comes to confusion. Most clinicians, when they're assessing, are not always looking at ability. They're looking at a person's desire to do something or wishing to do something, but not necessarily their ability. So consider medical restrictions when determining ability. Also, number 15, the 1 calendar day, and the 3 under the functional items are always worth reviewing, especially now when functional items are under such scrutiny and review. There's more, of course, case mix with functional items than with therapy, which means there's also going to be more scrutiny. So number 1, reporting the patient's ability, not their performance or willingness or desire to perform a task. That has to be stressed over and over. Because somebody says, I want to do this, doesn't mean that they can safely perform the task. And that's what we need to look at. And number 2 clearly delineates that. The level of ability refers to the patient's ability to safely complete specified activities. We've all taken the training sessions in OASIS where they identify the patient says, yes, I can get in the shower, I can do my shower. Then when you ask them to show you, what you find is they're clutching onto the shower curtain, they're holding on to the door, they're very unsteady on their feet. So are they safely completing the task? And we all know the answer to that. So these are well worth going over again with clinicians, and you probably just want to remind everyone periodically regarding these, because these are the areas that we do find are frequently misunderstood. Now, CMS also clarified 1730 depression screening. Depressive feelings, symptoms, and behaviors may be observed by the clinician or reported by the patient, family, or others as allowed by the standardized validated tools administration instructions. So depending on what depressive screening tool one is using. Clarity for in OASIS-C1 was added with instructions to indicate that the patient was interviewed, not the family or others. So this is important. They wanted to be certain that you were noting who was interviewed, the patient or the family or caregiver. Now, this also brings to the point that, yes, depression lost case mix here, but we also know that obviously we're not providing care for case mix. So we're going to have people who do have depression, and we need to take a look at who's going to intervene and assist. So when one organization recently told me, well, if I'm not getting case mix, it's going to be very costly. Really? Because more and more organizations are looking at having an OT on their psych team with great validity. When you look at a psych team, most of the time we think of having the RN there, the specifically trained RN. And that's great. A psych nurse, a mental health nurse, behavioral nurse, whatever your term is that you're going to be using, have tremendous skills, and usually those skills involve verbal discussion, verbal counseling and dialogue, helping individuals through various techniques, cognitive restructuring therapy, brief therapy, whatever it may be. But adding an OT to the team, research has found does assist to motivate the patient even more. In this case, while the RN is using more words to achieve their goal and displace feelings in a healthy manner, the OT is using activity. And so with many patients who are depressed, working out that depression, which, as you know, is frequently internalized anger or internalized feelings, working it out through activities such as using an angry pillow or using some type of art therapy, some type of painting, Those types of activities can help individuals displace those feelings into another inanimate object, sometimes a lot easier than verbalization. So keep that in mind if you're establishing a behavioral health or a psych team and you have a frequent number of patients who have depression, as we're seeing depression grow in our country, you may wish to expand your team to include an OT. Now, the functional scores were focused on. They added terms such as specifically to grooming, ambulation, ability to prepare light meals. They also changed the term compliance to adherence throughout Chapter 3, especially you'll note it in M1900. Compliance to adherence. Subtle change in some regards, big change in others. They got rid of unnecessary wording in the falls risk assessment. They used the term standardized validated, added throughout the OASIS-C1 for consistency. Again, take a look at your protocol regarding your falls risk assessment. If you're using the Mach 10 score and it's higher than 4, do you have a protocol that automatically requires physical therapy evaluation? You may wish to take a look at that. Some organizations that I audit, if the Mach 10 is 4 and above and the tug is 14 seconds and above, they want physical therapy evaluation. So the physician is notified. They eliminated certain abbreviations in the drug regimen. Adverse was added to describe drug reactions. Significant was added to describe side effects, and non-adherence was added to non-compliance. The reporting period for M2004 and 1015 includes the time of the previous assessment, and the measure refers to the physician contact for medication issues that have been identified. Again, they added the word significant to describe side effects. Now, types and sources of assistance. They did refine the headings in 2202 to clarify that a caregiver is not the agency's caregiver. And again, simplified response options to combine caregivers not likely to provide assistance and caregivers unwilling and unable to provide assistance, feeling that there was just too fragile of a delineation between the two, so they were combined. In 2250, CMS revised the non-applicable responses and the patient parameters for notifying physicians of change in vital signs or other clinical findings. So again, subtle but important changes. The wording for emergent care was revised to clarify that the reporting period includes the time of assessment. And notice, this is something they want to be consistent across this whole continuum of care. So it includes the time of the assessment. They also added the status to holding observation to bring it in alignment with the current instructions in the guidance manual. Now, they made all these changes. That's fine. They cleaned up and made the tool more harmonious with other tools. But the biggest thing, one of the biggest things they did was recalibrate or overhaul the 4-equation model. This is the biggest change in a number of years. This is the model that's used to determine the clinical and functional scores for the episodes. So I just wanted to note specifically for you that the 124 variable model saw 63 variables drop, 21 added, and it impacted all case mix categories. They removed case mix for 201 codes from pulmonary, that was hit very hard, depression, psych 1 and 2, blindness and low vision, and these were the major areas. They removed 170 some codes from the case mix status, and 2 basic items in 1200, vision and 2030 lost their case mix value. So when you take a look at this, what does this mean to your firm? Well, for some firms that are heavy in pulmonary, this can certainly have an impact. For those firms that do not use therapy much and rely heavily on their skilled nursing, those firms did see some changes. And again, the respondents to various surveys identified some of these case mix losses. Essentially what they were saying is they really hadn't looked at how could they replace them, what could they do to counteract the case mix losses. If you have, let's say, a very high diabetic population and that was your primary diagnosis, then this impacted you tremendously. So let's take a look at a couple things you can do. Some of those things, if you have a lot of wound care, you may want to take a look at treating those. Could you use silver dressings when treating a wound to reduce your daily visits to 3 or 4 a week? Can you take a look at if a patient has vision-related diagnosis as a secondary diagnosis? Do they need therapy? Do you have protocols in place for those specific needs? This is one of the biggest changes since 2008, and the functional scoring did undergo those changes that caused increased therapy values, and there's been a lot of discussion about that, and I'm not going to get into what's right or wrong. The fact remains that CMS hit clinical hard, and there was a reduction in case mix, but therapy, especially high therapy, 14+ visits, garners more points, and some people say go figure. There's reason for that, and we're going to talk about it. I listed some of the areas that lost case mix, and again, blindness, low vision. You saw that for those codes in blindness and low vision, optic nerve damage, impairment in both eyes, lost case mix. In Psych 1, this included your simple schizophrenia, your delusion disorders, and bipolar. In Psych 2, this included your Alzheimer's, your dementia, your drug-induced mental disorders, your alcohol-induced disorders. And in pulmonary, it included asthma and chronic bronchitis and emphysema. This is a big, big change. This was a huge hit to many organizations. And again, this spelled it out more specifically for you. For those of you who do not do coding every day, just having the numbers is frequently of little assistance, so added some of those commonly known diagnoses that we were impacted with. Now, take a look at, you still get case mix for certain diagnoses if therapy is involved and if OASIS items are answered specific ways. But for people with blood disorders or certain cancers, many of them would not feel therapy is appropriate unless, depending on the disorder or the specific need. Now, if diabetes was primary as the focus of care and there are conditions warranting therapy in the home, you still could garner case mix in this case. If indeed you also answered the OASIS M1030 1 or 3, and you see M1342, 1400, and 1620. So again, yes, and I hear you laughing, and I know why. Yeah, many people have had the same response because they're saying, really? When are we having 14 or more therapy visits out there for a person who has a blood disorder or a trach? So that was one area. Another area you could get case mix. All of these particular codes have been changed, no longer have case mix unless you had some therapy visits, and diabetes was, say, secondary and you had therapy, or heart disease and you had therapy. And the following OASIS items were answered in this manner. So again, you could see that the changes that were made hit clinical hard, but functionally therapy was almost rewarded, or the belief is that they're getting more response and better return on investment with therapy. And we have to consider that because obviously there is a real support of therapy in home health care. Now, CMS states that the changes were made to align the payments with current utilization data in a budget-neutral manner. So could this happen again? You bet it could. So what do we do about it? What can we do, especially in the clinical realm? Well, the documentation and the coding that they looked at the submitted claims did not support the depth of care delivered. And this was stated over and over in presentations that I attended by CMS. Essentially, it was stated that clinicians did not do as good a job as needed in identifying complex care. So the notes weren't as specific. The therapist notes were more specific. So for the nurses who are there who maybe are thinking, oh, I've read therapy notes and they don't look as specific to me, sorry. According to CMS, they are very objective, they're very time-oriented, and you can clearly see what the therapist did to justify the reimbursement. Not so much in many clinical notes, RN notes that were reviewed, or skilled care notes that were reviewed by CMS. So we need to do a better job in order to protect some of the remaining case mix diagnosis, and also, frankly, to demonstrate that maybe some of these other diagnoses that lost case mix should get it back. So let's look. When you look at the final case mix table, again, note we did lose everything case mix for blindness and low vision, but notice that one or two, that second column with 14 plus therapy visits gave you specifics on the final case mix table as to what diagnosis will garner the most points for you. So the total lines, 11 lines, lost case mix value, and again, the vast majority were clinical. And again, the reason that's being stated by CMS is in reviewing the data that was submitted, clinicians, and I'm an RN also, we didn't do as good a job documenting specifically what we did that warranted additional reimbursement under case mix, additional reimbursement because of the complexity. And I think sometimes we're so concerned about giving care that we don't document it as specifically. Now, if we're not documenting as specifically here at ICD-9, we're really going to have a problem with ICD-10, and we've really got to consider taking a look at that. Now, since we don't code for dollars or points, the diagnoses that no longer have case mix will still be coded in the future if they're supported by appropriate documentation. But note that CMS expects that we won't see some of these case mix or some of these diagnoses in the future. GERD is an example that's always given. The other area that was really focused on also was insulin injections. When an agency is providing a clinician to give those insulin injections, note this is going to be an area that's going to be monitored. The final rule listed 164 diagnosis and status codes that can assist to support the service. So note, if you are providing the injections from your agency, someone is going in to provide those injections, you are going to have a supporting diagnosis that would be something like, and I've given some examples here, Parkinson's, contractures of the joints or the hand, upper limb amputation or amputation of the hand. You're going to have a diagnosis that supports it. And there are various diagnoses. The final rule did list over 160 some of those. So some of those areas would be you're giving the injection because of an amputation or a vision problem, cognitive behavioral issue, arthritis, movement disorder, etc. There's an entire list of those. Now, it's not all bad news. There are still case mix diagnoses remaining, anemias, cancer, diabetes, in specific areas, which I gave you examples, dysphagia, stroke, GI disorders, etc. These still garner case mix, but we're going to have to document specifically in order to retain that case mix. So the real message from CMS is there may very well be a need, and maybe some of these diagnoses shouldn't have lost case mix, but the documentation is not supportive of that. It's supporting the fact that they didn't deserve additional dollars. So we need to keep in mind, and I can't stress it enough, those claims and those documentation with claims when they're looking at that has real meaning in the years to come. So if we want to keep our dollars, we've got to document. If we want to get our dollars in the future, and as I said, clinicians have to start documenting how and what they're doing and how much time it takes to do it. They've really got to get more specific. They've got to document more like the therapist. The therapists, remember, they're documenting and they're very cognizant of they're in there on increments of time. When RNs go in, we don't think as much about the increments of time. We see it as a visit and we're not as specific. We need to hone in on that. So there's danger that the documentation's got to improve or the payment's going to continue to decline. We're harming ourselves. Now, some of the things we need to take a look at is appropriately assigning the primary and supporting diagnosis to support the claims and making certain that there is the related orders and goals on that POC, and our plan when we're making those visits are relating to the plan on that POC. So each of those billable skilled visits need to show that they're a part of that particular plan. And according to CMS, that assessment, when you're looking at the codes, the way they're looking at it, because of the specificity coming with ICD-10, you should be able to see the codes listed as a table of contents. And from looking at the codes, you should know roughly what that assessment is going to show you and truly what you should expect to see in the plan of care and what the outcomes should be. So keep coding guidelines in mind, even if you're not a coder, because they can help regarding the documentation. One of the biggest problems we find when we are coding is the lack of supportive documentation for the recommended codes. Now, codes for symptoms, signs, and ill-defined conditions, we really can't use them as a principal diagnosis. This is what got hospice in trouble in the last couple of years. You can't use symptom codes as your primary reason for being in there. What's the primary problem of this patient? We need to keep in mind when there's two or more interrelated conditions, then we've got to identify the one that has the greatest need as primary and sequence it first. We've got to take a look at the fact that if there's a symptom, it's got to be followed by a comparative diagnosis. And again, there's got to be support in that plan of care. We've got a sequence, and according to CMS, we should be looking at the diagnosis in the order in which they have the need. So very specifically, a clinician should be looking at this is why I'm here. Here, of course, are the presenting diagnoses. Here, of course, are the active plans. And then the visits should relate to that particular plan. Everybody, I'm sure, knows that. That's not what CMS is seeing when they're looking at final claim data. We have to ensure that the diagnosis is the diagnosis most related to the patient's current plan of care. And it's the chief reason that we're in there. Now, as strange as it may sound, when I do audits, our audit teams find frequently that 25% of the records we're looking at have the incorrect primary diagnosis. That's truly not the focus of care, not given the diagnosis or the documentation that we're seeing. Now, for some of you, you're probably incredulous with that. And to me, when the data came in, I was, really? I mean, most of us know why we're in there providing care, but the documentation isn't supporting it. We need to ensure that all of the diagnoses under consideration for this patient that indeed they have the skilled services correlating to it. We need to make certain that the secondary diagnosis have conditions that are actively being addressed, unless, of course, they have specific comorbidities that the coding guidelines, the coding clinic has stated that these certain diagnoses will always impact the plan of care, thus they should always be listed. One of the examples is diabetes. General rules for other diagnoses for reporting purposes, other diagnoses are interpreted as additional conditions that will affect the patient's care in terms of requiring clinical evaluation or therapeutic treatment, impact on their diagnostic procedures, would impact their length of stay, or would increase their nursing care or monitoring needs. Now, the Uniform Health Discharge Data Set, that's what that UHDDS says, defines other diagnoses as all conditions that coexist at the time of the admission or that develop subsequently or that affect the treatment received and/or length of stay. So we need to be certain that we've got active diagnosis listed there, diagnoses that the coding clinic states should be listed no matter what, because they will impact that plan of care. Secondary diagnoses are comorbid conditions. I can't tell you how many times in audits I find numbers of diagnoses that aren't listed that truly would support that picture of the complexity of the care. We do ourselves a big disservice if we're not listing those secondary diagnoses and we don't have a plan of care there. Sometimes you'll find that indeed there's care being provided for the patient, but the secondary diagnosis isn't listed. Now, case mix diagnosis supported in documentation. Blood disorders, presently any blood loss anemia where there's new medication has been ordered, lab monitoring, note that. Any new diagnosis of cancer, an example, stomach cancer where there's G-tube feedings, nutritional deficits, teaching and training needed, diabetes, dysphagia, stroke. Look carefully at the care that would be needed and should be provided. Brain disorders, Parkinson's disease with a new onset of ability or inability to ambulate, anything that would require skilled therapy services, multiple sclerosis exacerbations, ortho conditions such as leg or gait disorders, any flare-ups of their arthritis resulting in the need of PT, any trauma wounds, skin ulcers, trach or urostomy. These are still areas that are supported, that with supported documentation can garner case mix. So the common elements found in the two sides of case mix diagnosis were that the documentation was directly tied to billable skills addressing problems or had exacerbations, new diagnosis, or complications. They were not diagnoses that were stable and predictable without problems or complications. Our best defense against losing further case mix diagnosis cuts is accurate, objective, and measurable skilled care documentation. That's what we have to do. Now, ICD-10 is going to demand it. We're going to have more specific documentation in order to use the combination codes in ICD-10. Many combination codes have a number of diagnoses within them. We're going to have to document the specifics of those correlated diagnoses. So the objective documentation that must be evident from the billable skilled note to the billable skilled visit note, one to the other. The skilled care has to be individualized for the patient's need. Be careful of any canned phraseology. Be very specific regarding the diagnosis and be specific in having the documentation there to substantiate those diagnoses. Now with 10 coming, the specifics as I was talking about earlier, a hip fracture is no longer just a hip fracture. we've got to know what type of fracture, what type of broken hip does this person have. So was it a pelvic fracture or a hip fracture? Was it a femoral head fracture, an intertrochanteric fracture, a femoral neck fracture, also known as a subcapital fracture? Was it a subcanteric fracture? These are specifics that we're going to have to know. We're not just going to be coding now broken hip. What type of fracture have they had? The specificity in intake is going to be essential. So they're going to have to, their referrals are going to have the specifics: where, when, length, size, details. Laterality plays a huge role with ICD-10 and retaining future case mix. With ICD-10 specifically, keep in mind, if in the hospital it was stated that the patient is left-handed, but at home the nurse does not verify that indeed they are left-handed, it's not noted as far as laterality, the coder could go to the default right hand. That will be an automatic claim rejection because it doesn't compute. It isn't, there is no congruency between what was listed on inpatient and the next level of care. CMS is getting very savvy now, and they want to be very specific in these areas. Now, we may see changes because a person was in an acute care setting. There may be some changes in some codes as they go to other settings. But whether you're left-handed or you're right-handed, it shouldn't change. And so it's these types of codes CMS is going to be looking at very carefully and noting those. They do predict that there's going to be somewhere between 10 and 20% denial of claims initially, rejection of claims. And basically it's going to be because of the codes. So the coder needs specific information so they can code to the highest level of specificity. And that means your intake department's going to have to get more information up front so that that clinician can get those other specifics that are needed. I want to mention to you that the word documentation is mentioned over 70 times in the ICD-10 CM guidance. Not so in ICD-9 guidance. Obviously, documentation is very important in ICD-9, but the stress of the word documentation in ICD-10 can't be emphasized enough. And like I said, over 70 times, 76 times to be specific. So the code assignment is based on the documentation of the relationship between the condition identified in the assessment and the care that was delivered. And it needs to be specific. The biggest problem that I see when doing audits is the documentation's not there to support the codes that were selected. Oh yes, when you go back and if you could ask questions, you'd probably find that there might be the documentation there, or the clinician just didn't put it down there. But that's something that we routinely are missing, and we've really got to improve in that regard. ICD-10 is going to demand it. So the specificity and documentation will be required. Gone are the days of writing CVA as in ICD-9. In 10, we're going to have to know the type of CVA, the artery involved, or whether it was thrombotic or embolic. So start now. Have the clinicians start getting into practice. We need this information. We're going to need to have more information regarding tobacco usage. It's not going to be good enough to state they smoke. They smoke how much, how long, what type. If they don't smoke now, what's there, and they have certain pulmonary diseases, we're going to be asking, were they in the houses where their family members did smoke? Have they ever used smokeless tobacco? CMS is conducting significant research in this area, and they're going to be demanding more and more specific documentation in that regard. So the clinical documentation directly impacts the reimbursement a home health agency will receive, but more importantly, will retain. It's got to be objective. This is where the therapist gets us every time. Their documentation is measurable, and it supports their diagnosis and the OASIS answer selected. The RNs, the skilled nursing, needs to do the same. The claims are going to continue to be data mined. They're going to be reviewed, and the important thing is we want to have the documentation there to support the diagnosis We want to be paid appropriately, but more importantly, we want to keep the dollars that we received. We want to retain them. So the big thing to keep in mind, everything will continue to change, and that should be okay. There is hope in that we just need to improve our documentation to retain case mix, and hopefully all of you are preparing right now for ICD-10, and you probably already know what I'm talking about. You've probably already listed your top 50 diagnoses and what some of the specific documentation that's going to be needed for each of those diagnoses. We're recommending that every clinician have a cue card with those specifics on it so they're ready for ICD-10. That's who needs the education right now, are the clinicians out in the field, so they know what documentation is going to be needed for your top 50 diagnoses. So, any particular questions?
Let me go ahead. I'm going to unmute all of the lines right now, so if you have a question, you will be able to go ahead and pose that. Okay, all of the lines are unmuted, so if you would just be conscious of that, everyone can hear you right now.
Okay, I did see one through the chat line, Heather, and that was, since OASIS ICD-9 removed the statement to use professional judgment, why do we truly think that occurred? And I think that occurred because, again, they are attempting to use very specific, validated, objective assessment tools and data. Are there other questions?
I have a question about how CMS actually looks at the documentation and evaluates it and determines that the nursing documentation is not meeting you know, what they would like to see. I mean, how is that process done? Who does it? When is it done? How is it done? That sort of thing.
Well, you know, I asked that very question when I was attending a state conference, and I believe it was in, don't hold me to this, but I think it was in Idaho. It was Idaho or Iowa, and there were a number of CMS representatives there. And they stated that they pull sample claims routinely, and they look at the documentation to support those claims. And while they find that therapy routinely is using very specific objective data, that skilled nursing tends not to do that. But they didn't give their specific guideline or their specific, shall we say, parameter list. Even though I was trying to hone in on it, they weren't forthcoming with that. Measure your knee and how far it goes. But you know, yes, for the person who just made that statement, that's exactly right. We should be looking at more specific objective data. And you know, the other thing we don't do as much, maybe your group does, but we don't use validated tools routinely throughout a specific 60 days episode. We should be repeating those tools like therapy does, so we can show that progress that's measurable. And there are a number of tools out there depending on your diagnosis, and we should be more tool related. We tend to be less tool related.
Thank you, thank you.
Any other questions? Well, the big thing is you don't want to be amongst a group that's losing around $101 to $300 per episode per the home health line of the April 27th print there. There's a number of things, like I said, you can do involving therapy more and also improving our documentation. One of the first things you may want to consider doing is analyzing your top 6 primary and secondary diagnosis and take a look at the utilization for that. This same home health line, and I've seen another similar survey, what many organizations found was they had similar utilization no matter what the diagnosis was. And you really want to take a look at that and probably provide some guidelines to clinicians regarding utilization for various diagnoses and categories. So, and, you know, take a look if someone totally exceeds those guidelines as to why, so that you can provide some education if needed. This was one area that many agencies found they could significantly impact on.
Great. Are there any other questions? Well, if there are no other questions, I'd like to take this time to thank you all for joining us during today's webinar. It's your participation and feedback on the post-webinar evaluations which allow the NAA to improve program offerings and activities. As a reminder, please have all quizzes and evaluations submitted by Thursday, June 11th, 2015. I would also like to thank our guest faculty, Susan, for sharing her expertise, time, and commitment to making this a successful program. Thank you again for your participation, and I hope you all have a wonderful afternoon.